considerations for left main PCI, generally speaking, different types of left main bifurcations, true left main bifurcations that you see. So what has already been mentioned is operator experience, and Anirban Chowdhury really illustrated that well with his own study from Wales. Really key. So the more experienced you are, the better you're going to be at it. Considerations that are important include the provision and the capability for mechanical support. Left main, after all, is the most critical place that we're dealing with. And whereas it might look very simple, you never know what can happen. And you may need to initiate mechanical support at some point, or you may in fact have to do it electively in somebody who has very poor LV function, who has no reserve. Intravascular imaging has already been mentioned, but critical that we have this in our quiver and that we know how to use it well, whichever that intravascular imaging is. And you may use OCT in some places with distal left main bifurcations. I quite like the results that I see. And IVUS obviously is going to be more commonly, especially in patients with kidney dysfunction. And of course, plaque modification strategies, which has already been discussed to a large extent, the various different techniques that we use. Anatomy is important, not just the Medina classification. Of course, it's important to know whether or not we are doing a true bifurcation or not in terms of decision for two-stent strategy, but it takes more than just a 1-1-1 bifurcation for me to choose a two-stent strategy as a default. Lesion length, obviously, we'll discuss complex, what constitutes a complex left main bifurcation in a little while. Bifurcation angle, I believe, will be discussed later. I think it's probably not as critical as it used to be. What is important that we actually don't talk about very much is actually the dynamic angle at the left main bifurcation, if you wish, the swing that the circumflex has from systole to diastole. I think Antonio Colombo published a very nice study a few years ago that in fact showed that the more dynamic that angle is, the more it deviates, that the worse the results with left main bifurcation with two-stent strategy. And finally, lesion complexity. Again, we'll discuss that a little bit later. So just a brief case, and I'm not going to be showing a lot of cases here. I think I'm doing another talk tomorrow at 5:31, where we'll be discussing techniques and technical strategies with left main bifurcation. So this is a 65-year-old man with severe COPD, class 3 angina, was a complex 1-1-1 bifurcation, quite heavily calcified, and we used various modification strategies here. I won't show you the case for sake of time at this point. I will show you the critical step at the end, and that's the pot. The pot, you cannot do enough pot to get a successful procedure, an optimal procedure in bifurcation stenting, especially left main stenting where it matters the most. And this is our final result, I believe. Very nice result in this man with a very critical left main true bifurcation lesion. Now, I can barely see this, but this was actually published a few years ago by Tanvir Rab and Xiaoling Chen and colleagues, essentially explaining, derived on the definition studies. Okay, maybe I can get rid of that. Yes, definition study. So, first of all, considerations for left main bifurcation, whether the side branch lesion is greater than 70% or not, whether the length is more than 10 millimeters. These are two important constituents of the definition, if you wish, of complex bifurcation lesion. So this would be a complex lesion which would necessitate a two-stent strategy in the view of this group, and we would do the side branch first. The recommendation is for DK crush stenting, which is usually my recommendation as well. That's the Asian Bifurcation Club consensus as well. And in the cases of a less complex strategy or bifurcation, if side branch access is easy, then you would actually proceed with provisional stenting. If side branch access is seen to be as difficult, and I would certainly agree with this, we would go with 2 stents first strategy. And again, you could go with DK crush. You can go with a tap or collide. I don't actually like tap, and I actually do like the reverse crush better than the tap because you don't get the neocarina, if you wish, the metallic neocarina, especially with the narrow angle bifurcation. So I think that's a tough one for me. Or you could use the culotte technique. The problem with culotte, I think, in left main bifurcations is that not some side branches are so large that you're going to end up with a napkin ring at the ostium with your culotte technique because the cell is not going to be large enough to support that. So that's a problem that I do have with using culotte routinely in these bifurcation cases. So DK crush, I've already alluded to that. It is my favorite. What are the data for this? DK crush 3 versus the culotte technique. In simple and complex left main bifurcations. So in simple, we can see with DK crush, 5.8% MACE at 3 years versus 10 with culotte, but it gets even worse with complex lesions, where with DK crush, the MACE rate is 15% versus 51% with the culotte technique in complex bifurcation lesions. So I think this is certainly a bit of evidence for me. Now you could argue that people who do a lot of DK crushes are probably not going to be doing a lot of culottes, except perhaps in the trials. I don't know, but it is possible that there is a more of a. You could argue that this starts at the angiographic follow-up and is falsely elevated in terms of the MACE rate in the culotte technique. But in fact, this continued out to 3 years. And at 3 years, there was still separation of these curves. And so I think it's pretty good evidence, at least from this group, that DK crush is superior to culotte in left main bifurcation stenting. In terms of QCA, of course, in the group of patients who did have angiographic follow-up, there was a doubling in terms of restenosis in the culotte group versus the DK group as well, which contributed, I'm sure, to the MACE rate. Now, let's go to DK crush 5, which was the DK crush versus provisional trial in left main bifurcations. And of course, at 12 months, there was a significant difference, a benefit towards with DK crush over the simple approach. Just to mention this trial, though it's not strictly speaking in left mains, but it was a trial that showed somewhat better outcome superiority with the culotte technique over tap stenting. So I just wanted to mention this trial, but it wasn't specifically in left mains. You can see that TLR occurred in half the cases that it did with tap stenting. So at least compared to tap, this technique was superior or almost superior. We then have a systematic review, which I think is very nice. That was published just last year, comparing the different texts. So these are 26 randomized trials that were comparing the different bifurcation strategies. For sake of time, I'm going to just point to comparisons with DK crush, and as we can see, DK crush is superior in all of the randomized trials where it was tested against other strategies: tap, culotte, dedicated bifurcation stent, T-stenting and provisional stenting, as well as regular crushing, which was done in one of the DK crush studies earlier on. So, complexity definition criteria were created through a registry by Xiaoling Chen's group. They came up with one major criterion for left main and non-left main, and 6 minor criteria which were independent predictors of outcome. And what constituted complex lesion was 1 major and 2 minor of these 6 criteria. Based on this, then they designed and carried out the definition 2 trial, where they took only patients with complex lesions, not all left mains again, and found that the lesion length here was considerably longer than any other trial previously in the side branch, 20 millimeters, so complex lesions for sure. In terms of technique, DK crush was used in 3/4 of them almost, but not exclusively. And what they found, I will leave this except to say that there was a significant benefit to two-stent strategy in this. So should we only do, and I'll stop with this, should we only do two-stent strategy in definition complex patients? I would say no, and the reason for this is that when we look at DK Crush 5, when the analysis was done in definition complex and definition simple patients, for sure there was a clear benefit in definition complex patients out to 3 years. But as you can see, there's a strong trend also in definition simple patients. So all true bifurcations. And for this is simply underpowered. You would need an N of 407 per group to show this to be significant. So this is simply, we cannot say that there's no benefit in the more simple true bifurcation lesions with this study. For the sake of time, again, I'm going to leave this alone and just go to my wrap-up slides. EBC main, even though carried out long after all the DK crush studies, actually had no DK crush patients in it. So we have clear evidence and clear guidance for randomized trials regarding patient subset that benefits from a planned two-stent approach, irrespective of strategy utilized. Meticulous technique is required to ensure best patient outcome. That is optimal lesion preparation, which has been discussed previously. POT, and POT, critical, very important, guided by imaging. Left main PCI should be performed in facilities equipped to deal with complex anatomy and the complex patient. DK crush, from the evidence that I see, provides the best coverage of the side branch ostium, best geometry of any technique. It is the only technique to have randomized trial superiority evidence against the provisional approach and culotte in left main PCI. It needs validation. We're planning and hoping to do a Pan-American study called Access 1 of DK crush versus provisional approach. And thank you very much. Sorry about the technical difficulties in the talk, and thank you for your attention.